Welcome, everyone. First of all, my name is Jerry Williams, and for those of you that don't know me, I am the founder and president of Myositis Support and Understanding, and we are an all-volunteer, patient-led nonprofit organization working daily to improve the lives of and empower the myositis community. With me today are all of the authors of this paper, right? This paper that we've been sharing and providing you information today, over the past few days. And today we're going to talk about pain, but we're also going to talk about the power of our voice and how our voices as patients, as an organization, led to this seminal paper on myositis and pain treatment. And I want to quickly welcome our panel and co-authors of the paper, Pain Profile and Opioid Medication Use in Patients with Idiopathic Inflammatory Myopathies. So aside from myself, joining us today is Emily Filmore, co-founding director of MSU and board member emeritus, Lynn Wilson, vice president and director of patient-centered research, Manuel Lubinus, our chief science officer, Dr. Bhai, our medical advisor, Dr. Abhi, a research partner, and he'll be joining us shortly. So welcome again, get settled. If you have questions, we do have questions that you submitted during registration. We'll start with those, but feel free to locate the Q&A icon on your Zoom toolbar. And if you have questions, please feel free to put those questions in there. Questions about pain treatment, pain and exercise. We have two wonderful experts here that can answer some questions and maybe direct to some resources. So here we go. Lynn.
Hi, Jerry. Thank you, everybody. Glad to see you here. When we were putting together our fireside chats, one of the things that we wanted to do was be able to talk about the power of the voice of the patient. And with our FDA session, fireside chat, we were able to talk about the power of telling your story to the FDA and what it meant for us. And today what we're going to talk about is a different way of telling your story or amplifying your voice, and that's through the data that you provide when you do surveys and other types of panel discussions, focus groups, questionnaires. And it all has impact and meaning. And so we wanted to give you another behind the scenes and what happened to our initial pain study and how it led to a published paper in Rheumatology. So the agenda for today is just casual conversation. And as it turns out, there's a sequence to this. We're going to have Jerry and Emily talk about the call to action that precipitated the study and the development of the survey. Then Manuel and I are going to talk about how we got it off the shelf and into the hands of our champion who pushed it forward to publication. And then you're going to get a few insights from Dr. Bhai and Dr. Abhi about what it takes to get published and what the implications are for this study and this paper to the myositis community and what the next steps are. And then we'll hopefully have maybe 15 minutes or more to talk about Q&A on pain and pain treatment, because I know that you all have questions about that. So let's just get started. And I'm going to turn it over to Jerry and Emily for some conversation about how did this all come about? Tell us about the call to action. Jerry?
Thank you, Lynn. For those who don't know my journey, pain was my very first symptom back in 2003. And pain was one of the reasons my diagnosis was held for so long, even being diagnosed as being psychosomatic, because the doctors said it couldn't be myositis because you have pain. And through the years, struggling with finding appropriate pain management has been an issue. And I was doing stable on these opioid medications that I finally got into a pain management specialist, and things were going well until 3 years after the 2016 CDC opioid guidelines came out. And my doctor decided that those were the law and began drastically decreasing my opioid medications in half, not doing a proper step down or anything along those lines. And Emily, has a little bit better of a memory of this than I do. I had, as part of my journey, 2 strokes. So on top of the brain fog, sometimes the strokes affect my recall. So Emily's going to talk a bit about how my experience inflamed her. She just was a monster, just ready to pounce on pain, and together we did. And I'm so grateful that you're here today, Emily, to talk about this with me and with all of us.
Thank you, Jerry. Well, how fitting, because the motto for Myositis Awareness Month was "Hear Us Roar," and we have a tiger on our agenda here. So yes, after working with Myositis Support and Understanding for so many years, and becoming so close with Jerry and various members, and hearing over and over about doctors telling patients that pain didn't exist with myositis and that opioids were getting cut because of the CDC guidelines. I remember having one pivotal conversation with Jerry where he just said, "I don't know if I can continue on." And I don't know how many of the people on this call at this point are people who know me well, but I'm a mama bear. And I was enraged, as Jerry said. And I, being a former attorney, was reading through the guidelines, and it said over and over in the guidelines that this was for acute use of opioids, and chronic pain patients should be, dealt with according to their personal situation and all of this stuff. And so I just looked at Jerry one time on a FaceTime call or whatever, and I said, "Jerry, there's got to be a way that we can get this doctor to understand." So we were constantly advocating for patients to print out the actual guideline and print out the information that were opinions attached to the guideline and take it to his doctor. And his doctor, and believe me, I don't have this good of memory. I went back through some of my notes, and his doctor said to him, "Well, I have another patient who was only on opioids for 6 months or a year, and he's fine now." And Jerry said, "Does he have myositis?" He said, "No, he had knee surgery." And I was like, "You said what?" And so Jerry said, "Well, do you think that he's the same as me?" And the doctor said, "No, of course he's not the same as you." And Jerry said, "Then why are you holding me to the same standard of getting better?" And the doctor said, "Because I could lose my license. I'm in trouble for having other patients on opioids too long." And so I met with Jerry and Lynn, and I said, "We've got to do something. First of all, we can't continue having doctors telling our patients that they don't have pain, because it's extremely invalidating. And secondly, we can't have patients continue to post in our groups and tell us personally that they're considering suicide because of the inability to get help for their pain." And so we decided to contact Dr. Lisa Christopher Stein, who is at Johns Hopkins in the Myositis Center, and ask her if she had any guidance. And through our conversations with her, what we came up with was to put out a tiny little survey, no big deal, of questions of how many of our patients are actually experiencing pain, how many of our patients are getting opioids, or how many patients are experiencing other treatments, natural treatments, manipulative treatments, and the whole gamut. And are they being refused opioids if they've been on them before? And there was this long list of questions. And so over the next few weeks, and actually I looked, this was in May of 19, so 3 years ago right now. Sorry, my math is not great. We proceeded to write a very in-depth survey, and we went through all of the going through and making sure we got all of the opioids included in the survey, all the different types of pain that we could think of. And we really just wanted to pinpoint, were our patients experiencing pain at the high of level that we thought that they were based on the anecdotal evidence in our groups? And were they getting rejected for pain treatment, or were they being rapidly decreased at the rate that we thought we were seeing in the groups? And Dr. Lisa was amazing. She helped us with kind of conceptualizing. And we actually did get a little bit of advice from some outside people aside from her, which was amazing and wonderful. And what we really expected out of this first survey that we did was we were going to get some guidance from our patients, and then we were going to go forward and maybe even do a larger scale survey. But what we didn't expect was the amazing response we got from that first survey. And I don't have the number in front of me, but I believe it was like 450 or 480 responses. We were absolutely floored. We love you to our community at MSU because you just showed up. And what's so amazing about this survey is that we thought maybe we'd get a couple hundred. I mean, I always think big, and I thought, well, what if we get like thousands of people? But you never know where you're going to land. But 450 or 480 people, because again, I have a horrible memory of numbers, is so huge. And what we found, which the doctors will give us a much better explanation of, is that what we were seeing in the groups actually did play out in the numbers, and people are having pain across the board, and people were getting their medications taken away from them, and it was being detrimental to their lives. And so Jerry, as always, is the wonderful catalyst of change and is able to help us. His experience, which is horrible, and I'm so sorry that he experienced that, but he helped us to be able to show that other people were experiencing it. So I'm so grateful to Dr. Bhai and Dr. Avi that they were able, with Lynn and Manuel, to take this forward. And now we have shown the world that myositis patients have pain, and we're hoping somebody else, Dr. Bhai, somebody could take this and make a bigger study that proves it even more, and that we can now get doctors to listen to us, because it's so scary and so lonely to walk into a doctor's office and have someone say pain isn't real when we know pain is real. Did I miss anything?
Yeah, and Emily, I thank you for your support during that time, because I was calling Emily quite often and telling her those things. I had those suicidal thoughts. I'm not trigger warning, a little late on that, but I think it's just part of the reality when you're in so much pain. So being open and honest about that, you're not alone. So if you're struggling with pain right now, please know that you're not alone, and that we are working to help find something that can help. So please reach out. That's one thing I just want to be sure everyone knows, that please reach out to us. And this survey again was amazing because of you, and the power of our voices collectively. It's when we all come together that we can truly make change. And now we can show those doctors that no, pain does exist with myositis. So I hope that you will all take the opportunity to share this with your doctors.
I'm sorry, just one more thing. I failed to mention that I don't know the year exactly, and the doctors maybe can supplement this for us, but when I've spoken with doctors, it's only in the last decade, maybe, or less, that the medical textbooks are not saying that there is no pain with myositis. So it isn't 100% the doctor's faults that we're coming up to who are saying there's no pain with myositis, but we're hoping that we are a major part of dispelling that myth, because it's very clearly a part of, when you have muscles that are being attacked and joints that are being attacked, and it's very hard to understand how anybody could not understand that, but it isn't completely the doctor's faults. And so we're just hoping that this seminal work will help them to have a new understanding. And that's all I have. Thank you so much for being here with us.
Thank you, Jerry and Emily. We'll take it to the next step, and then we'll get Dr. Bhai and Dr. Abi in at the end of this to give us some insight. So we had this wonderful survey that every day we'd say, oh, we got 250 people responding. Let's boost it a little bit and see what we get. And so at the last day, and keep in mind, this was 3 years ago, almost to the month, It was in June, I think, that we ran the survey. And we ended up with 469 responses. 469. And after the euphoria of seeing the results, which in all honesty, I knew that we had something. We all knew that we had something here, but we're novices at the process, and we didn't really know how to take it forward. We were, we let it sit for a while, and we think, well, we've got to do something. We've got to find a partner to partner with us, to help us push this forward, to help us understand what we have here. And so it was like a constant every month. I'd think, what are we going to do? We just don't want to, we had all the information, but it was just sitting there on the shelf, so to speak. And as time went by, I thought, well, we have this information. There's insights here that we need to mine. And we still have a hunger and a passion for making some change, but we didn't really know how to go about it. So about that time, this was in let's say we were 6 months into it. We get an email from a gentleman by the name of Manuel Lubinus, who I had met at the TMA conference in 2019. And he says, I think I'd like to come and volunteer for your organization, because I believe what you believe. And I believe that this is a place where we can work together to ensure that we help people live a fuller and more of a quality of a life by providing the services and support that we do. And so, not knowing what we had here, or what the type of a volunteer that Manuel was, he just took the bull by the horn, so to speak. And this little survey that was sitting on a shelf and not getting the love and attention that it needed, all of a sudden began to find a place. And then Manuel and I would talk about it for a while, and then something else happened, which was, Manuel, you want to talk about what happened?
Well, I think after that, we have all this data. We have a lot of crosstabs. We found a lot of very interesting information. I think what will happen next is that we have Dr. Bhai joining us. So that was big, because I'm in Dallas. He's at UT Southwestern here in Dallas. So it wasn't a coincidence that just happens. And then all of a sudden, we could actually share with him, like, oh, look at this data. It's very interesting. There are some very interesting crosstabs about the people having pain, typos by different type of myositis. And then he agreed with us. He said, wow, this is very interesting information, very robust. So I'm sure that we can actually take it into a publication with that. And actually, we can bring the voice of those patients. Because for me, it's that we are sitting on this data that has been actually generated by patients. It's patient created. From the community. So, and it's exactly what we want to do, is engage the community and kind of provide research that we have from ourselves and communicate that. So having somebody like Dr. Bhai who came to say, okay, we can actually do this, and we can actually set it up with the right statistical methods, to chi-square, to the variability. So that was very important to us. So before we actually had to do any software ourselves, we got a collaboration with Dr. Abhi in Boston, and so we all of a sudden had a team to do this. So it was very, actually, this type of connections kind of grew organically, and just by serendipity, we found ourselves with having really all the information needed for the publication. But I think I don't want to discard the role that originally played off, that is very, very important, is the role of both Emily and Jerry, because come up with the idea that we really need to do something. And to me, that's the most important thing. When as patients, we realize that we actually had the power to change it. We don't depend on somebody else. We can actually do something if we work together. So to me, that's one of the greatest parts of the whole collaboration.
I underscore what you're saying, Manuel. That's exactly how I felt. And so I think the next step is that we should turn this over to Dr. Bhai, and Dr. Abhi will be in soon. And let's talk about this whole process because, part of what we're doing here is educational too. One of the things that we are trying to demystify is the whole process of research so that people understand what goes on, how you have to craft surveys, how you have to rigorously analyze data, and how that leads to other questions to ask and to answer, and that leads to more research, and that finally can lead to hopefully preclinical, pre-research or preclinical trial design. And it's a long road, and I never in my mind would have guessed that I would be involved in something like this. So one of the things is not only to talk about this, but to also educate you in the process. So this is where Dr. Bhai and Dr. Abhi come in. And we turn this information over to Dr. Bhai and say, can you help us here? We think we have something, but we're not quite sure. So Dr. Bhai is going to talk to you about the whole story about how you get published and how you shoot for the stars. And if you're going to publish, go for the biggies, that being rheumatology. So Dr. Bhai, take it away.
Thank you. And thanks to everybody up here for organizing, telling their stories, and giving some background. And especially thank you to the people joining here to listen and those who participated in these surveys. Speaking to your point, Emily, you're kind to think that the doctors are not at fault, which is the case sometimes, and sometimes that's not true. But thinking back to my training where I wrapped up my residency and fellowship just a few years ago, even then pain wasn't quite talked about, right? It just happened to be this thing that it could be there, it could not be there. We know it seems to be a part of the disease, and once you treat the inflammation, it should go away, and that was that. And then patients would be, sadly, the term is punted around, right? Pain is not it's not my specialty. Go to a pain specialist or go to a different doctor. And that's difficult for patients like you who it's hard to move around, right? You sometimes travel to a large center that's further away. It's costly for your time and your finances. And so I think all of that to me, and when I saw the data, I said, wow, this is interesting because this is not at all what we're taught. It's not at all what we think we see. And we need to make this more apparent. And so that's how it all started to kick off, right? We saw this data and said, this is quite prominent, right? Of the over 400 participants, 90% or more had pain of some kind currently or in the past. And almost 100%, 99%, attributed their pain to myositis. That's extremely high. And what I would say you might run into is, say if you show your doctor or talk to doctors about it, they might say, well, it may not be myositis, it may be other things. And I think that could be partially true, but I think the patient voice is important here, right? If you think it's due to a certain condition, that needs to be addressed very directly and worked up properly before someone kind of waves it off and says, hey, this is not due to your disease, this is due to something else. What I see clinically, and I focus on patients like you, is the pain is typically multifactorial, like it is in a lot of diseases. The muscle inflammation can cause pain. The weakness eventually can cause pain. If there's osteoporosis, there can be pain. The weakness can lead to biomechanical abnormalities that then cause pain, right? So it's this vicious cycle that then is hard to disentangle. And now you're stuck with this pain that's difficult to treat, that doctors may not understand, and you may get shuffled around trying to find the right answer. The biggest thing that we found from the survey is, one, that nearly everybody is in pain or had been in pain. And then two, we put it in here, but it wasn't coded in a way where we could completely get resolution on the kinds of medications people are on. But there's a huge list of medications that people like you try, get cycled through, and don't seem to find an answer. Whether it's opioids or NSAIDs like Advil or Aleve, Tylenol like acetaminophen or paracetamol. There's a lot of nerve medications we use. They fall into the category of antidepressants or tricyclic antidepressants. herbal medications, steroids, all of these things have been used. We're just not clear what's most effective. Before I keep rambling, I'm going to stop here. Lynn, what else can I answer or talk about? I see some questions popping up here.
Yeah. Well, I think one of the things before we get to what does it really mean for the community to have a declaration that there is pain, significant pain in myositis. But before we get to that, one of the things is I think it's important for people to understand is that our survey was not a research validated survey. And so even though we had a lot of data, you and Dr. Abhi had to go through some gyrations, let's say, to get it to the point where a publication like Rheumatology would accept it.
Yeah,
and so that I think that underline is very important to understand too.
Yeah, that part took a lot of work, a lot of manual time to recode the data to make it accessible to the kind of regression analysis that Dr. Abhi did, and how we went through and tried to pull out questions and data that could be answered. Right? When you have so much data, you have to go in rather than just analyzing it. We have to go back, and I with the MSU leadership, we take a look and say, what is a good question that we could ask that then could be answered by this data? And how does that data need to be coded so we can analyze it properly? So that took quite a bit of time, but once that was done, we were able to get great results. You may have participated in our more recent survey, and that was created by several validated survey instruments about quality of life, about ability to exercise, about the kinds of medications and pain that you're in. And I think having that approach, that rigorous approach up front, can only amplify the patient voice, right? And then there becomes no question of, well, how good is this data? It becomes more of a, wow, that's interesting. These are validated surveys. We can compare them across populations. How do we take this further? And hopefully that's what we did with this next survey. So we're in the process of analyzing that now.
So, okay. So then the next thing that we want to talk about is that, so we get the survey completed, and why don't you give the people in the webinar here a little understanding about to publish or not to publish? What do you do?
Yeah.
How do you make the best of this? What is the strategy around publishing?
Yeah, I think this speaks to the importance of people living with myositis to have a seat at the table for what's happening to your care. We know that myositis is inadequately treated, right? We need more. We need more targeted therapy. We need to know what the heck we're doing, right? Oftentimes we're just throwing meds on and guessing that you might have myositis or don't have myositis, or your disease is active or it's not active. So I think it starts with that, right? We need to know more. We need to learn more. Rather than having just physicians or healthcare workers or researchers guide where this is going, I think it has to be met with patient voice and interest. And that's where the publication comes into play, right? You know what this disease is so intimately. I do not, right? I see you for a snapshot. I think about the disease. I read about the disease. But that snapshot is not enough to catch me up on what your life is like day to day. And that might give us researchers insight into what we're missing here, right? And maybe it's a different outcome. Maybe it's a different biomarker. Maybe it's a different treatment. But your voice is key in getting research to move forward. The way we do that, I think most loudly to the research community is through publications that have high impact factors. And so this is one of those where, I've already had comments about this and people saying, well, that's a super interesting study. We talked about it at a department meeting today. And it's something that now it's just amplifying that, hey, we're rewriting what this disease means, and that can allow us to take it forward. So another study that we're thinking about and I'm trying to plan is, well, we have pain. How do we best treat it? And so we can do practical trials. They're called pragmatic designs, where we try different medications and see of the common ones we already use, what seems to work best for patients, rather than you having to try 5 or 6 different medications and still getting a result that isn't good.
That's excellent. That's kind of what I wanted to get to, the point that that this allows high impact and conversations going on amongst researchers about, how we can take this data forward.
And then I should add, sorry to interrupt.
No.
And I don't mean to make it sound like we only need to attack this from from the ivory tower, right? We're not just trying to publish and get researchers that way. I think it involves grassroots work too, where patients talk to their doctors, where patients have community events and patients educate each other. I think that those two should meet in the middle, rather than just say, hey, it's the doctors, you got to train them and teach them and do all this stuff through publications. I think it's more than that. And that's what MSU and others will do to hopefully educate more broadly. And eventually, if there's things that need to happen with trials, outcomes from that listening session, if there needs to be policy changes, all of these things require that ivory tower approach, right? Publish data, understand what's happening, but also have that patient voice constant throughout at a grassroots level.
Thank you.
Lynn,
Yeah,
can I
sure.
ask Dr. Bhai a question? I'm really glad that you made that last qualification there, Dr. Bhai, because in my observations over I don't remember how many years I've been with MSU, Jerry would know, but I think the thing that I've noticed is that no matter how many articles patients write for Myositis Life, or how many times MSU puts together an article that says, here's the current understanding of pain, I think the fact that there was any kind of study lacking that said, here's some data, the doctors that didn't believe in pain, or that didn't believe that opioids being taken away from myositis patients, that was the problem. So I think that even though you're distinguishing between, we shouldn't always have to have the ivory tower, we also need the patients to be out there advocating for themselves. And I think we still needed that ivory tower to validate it. Do you think that's correct?
I think we need a mix of both. And once we get both, I think that helps with not only the education piece, but it furthers what we do for actually having an impact, right? I think some of the problem is if you say, hey, this is a problem, here you go. But if you don't give solutions at the same time, I think that can make it quite difficult for physicians and patients, right? Where okay, now you've identified something, but we still don't know what to do about it.
Yeah, that makes sense. Yeah, I remember being at a talk for myositis patients, and I don't remember which doctor it was, and it doesn't matter, but he was very adamant to a patient who was asking about how to help her pain. And he said, well, you need to go back to your doctors because there's something else wrong with you, because polymyositis absolutely does not cause any kind of pain. And she ran out of that meeting in tears because she felt completely invalidated, and he just like cut her off. And he was at the time, a renowned specialist in myositis, and he just completely cut her off and would not even contemplate any possibility that he was incorrect. And it was so demoralizing for her and very many other people in that room. And so no matter how many times some patients tell their doctors, I have pain, they aren't going to hear them. And so I think that from our perspective, at least, being able to say, here, Rheumatology published this, and hopefully the subsequent ones that you and your colleagues are going to be able to come forward with, that will hopefully also have some solutions. Maybe that would validate them, because there are very many times that, even as wonderful as my doctors are, that when I say I think this has to do with my myositis, now I have, multiple other diagnoses too. So they first say, well, let's make sure it's not from that other thing. But, I think even people who only have myositis come up against that wall a lot of, well, that can't be myositis. So now at least maybe this will open the door for doctors who weren't able to accept pain as a symptom to see that it is possible. So I really thank you. I'm just so amazed at the work you did with this, and I appreciate that you're willing to take it forward and do other studies to clarify it more. So it's really a great thing.
I appreciate it, but really the work was through you all, right? Getting that data and then patients wanting to fill that out. And again, I think the limitation usually is getting good data, and having people who are interested and willing to put the work in to help us get quality data makes a huge difference.
Thank you. That's very kind.
Thank you. And actually, that's a good segue to Jared. Did you have something you wanted to say?
I was just gonna just kind of reiterate based on what was just said. You know, that's the power of our voice. So take these surveys. I mean, it really does matter. You know, it really, really does. As you can see, it's just continue getting involved.
Right. Oh,
and Dr. Abhi has joined
hey,
us.
I knew if I delayed a little bit, he'd come on. Dr. Bhai, would you go ahead and introduce Dr. Abhi to our patients here?
Yeah, absolutely. So Dr. Bhashyam is one of my best friends and colleagues. We did medical school together and then trained at the same hospital. He did his PhD in clinical research and is just an absolutely brilliant person. He's a hand and upper extremity surgeon and an orthopedic surgeon, but he specialized in that. And we're working on various collaborations together. He just came out of a very busy clinic, and so I'll let him fill in some more blanks here. But we were just talking, Abhiram, about the pain study and where we're taking it next, as well as the importance of patient voice and getting quality research data from people who are very willing to participate.
Sorry again that I'm late, but appreciate having appreciate being involved. I guess the best way is to solicit questions and then answer them, because I think usually the best research comes from patient-driven questions and clinically important questions.
Okay, so yeah, we have a lot of questions. I think I just wanted to wrap up one thing is that Dr. Bhai, and maybe you can talk a little tiny bit more about this, is that, or we can answer them as the questions come, but that's about the next steps that you see further research that we will be doing as a result of this first study.
That's a great question. I think the purpose of surveys like this is we call them hypothesis driving research, and needs assessment research. So identifying problems and identifying the scope of those problems, and then using that research to then launch more research. And that's research that's less about diagnosis and more about therapeutics. So for example, if we identify that certain types of myositis patients have particular types of pain, or maybe the data suggests that some pain medicines may work for some patients and not others, the next step in terms of the mechanisms of research is to do something called a prospective study. So rather than looking backwards, we look forwards. So we pick particular medications for particular types of patients. We investigate prospectively, looking forward into the future, and we then see if the interventions we make a difference. So I don't know if we talked about one of the recent surveys, but for example, looking at patient financial burden is a great example. So we've looked at patient financial burden in patients who've had musculoskeletal trauma or fractures. We've looked at musculoskeletal or financial burden in patients with cancer. And we've seen that financial burden is huge. Getting to appointments, distance traveled to make an appointment, time off to make it to the appointment, and then getting caregivers and others to also be able to make it to the appointment. And so the first step in that type of research is identifying what's the scope of the problem, and then what are the pain points. So where are areas that we can intervene to make patient lives better? The next step of that research is then, okay, so if we can come up with ways to advocate for paid financial sick leave or paid time off, or to have better accommodations for work, then those are things that we can advocate for at a bigger policy level. And that's one of the things that I worked on in my master's, is how do you take research data and transform it into policy changes or transform it into systems changes. And so that's what this research helps to drive. So it's a little bit of a long-winded question, but this is the very first step to being able to do a lot more directed studies.
Thank you. Yes. Okay, I think with that, we've got lots of questions and we should just dive into those questions. This is from Stephen. Congratulations on the paper. Musculoskeletal pain is complex. If you're reading that, if you can hypothesize pain in myositis is likely related to acute inflammation, chronic damage, abnormalities, weakness, and deconditioning, what are your thoughts on the statistical difference between IBM and DMPM, even though they are all inflammation and chronic damage?
It's a great question. And, we know that pain, as I was mentioning, is multifactorial. And you talk about that here, where you get not only deconditioning from a metabolic standpoint, your exercise tolerance decreases, you have marked fatigue. There's also that inflammation that happened early. Then there's chronic inflammation that can be underlying, and there may be fatty replacement of muscle that then leads to biomechanical abnormalities, right? You start walking funny, you start compensating in different ways, and then you become less active and you might get degenerative changes. So that can affect your nerves too. It's quite a complex picture. And related to IBM versus PM-DM, I would say that they're pathophysiologically different, right? We know that PM and DM can present more flagrantly and can flare up and down, whereas the IBM, because we can't make a dent on it, it just slowly progresses, and some patients progress faster. But that difference may relate to some of the issues we get about what we find between the two. The higher likelihood of pain in DM compared to IBM, I think, is related to that, where they have these flares, they can have pronounced weakness that remains because some people are not treated aggressively, or the disease is just very difficult to control. And that in the long run, I think, plays out where patients with DM have this pain that just doesn't seem to go away. Whereas IBM, they develop it and continue to develop pain and weakness, but it's not as flaring, right, as DM is.
Well, this person asked, she has knee pain, had an MRI last year, no problem except bursitis. Legs don't hurt, but could this pain be from IBM?
I'll let Dr. Abhiram talk about this bursitis. And there's another question too of Michael Matthew asks, what kind of pain? I have bone pain.
Yes, and along those same lines is the muscle pain. Is it the myositis? I guess this is regarding muscle pain, and what is best treatment for muscle pain? That kind of goes along a little bit there. Dr. Abhi?
Sure. I guess I would say, one of the interesting things that's starting to come out of our recent study is how few patients with myositis actually end up seeing orthopedists or musculoskeletal experts. So I would first preface by saying, a lot of orthopedic surgery can seem intimidating because it feels surgical, but a lot of orthopedics is actually non-surgical. And it started as a non-surgical field that has become specialized. The second thing is that, yes, it could be muscle pain or it could be myositis type pain, but oftentimes the most common causes of pain are the ones that are common across diseases. So it may still be a bursitis type pain. It may still be a tendonitis or something that's more common, and it could be overlapping things. So in medicine, we have this concept of Occam's razor. So we look for the simplest diagnosis being the one that explains the most number of things. But when you have something like myositis, plus you have a host of other common things, that's one of the benefits of slowly untangling which part is causing what symptom and figuring out how to tease those apart and trying to actually treat the ones that we can treat, and then figuring out what it is we can't treat and making that a source of, well, is there something we can do to make that better? So could it be bursitis plus something else? Yes. All things considered, it's probably bursitis given how common bursitis is. And then is there something to do for muscle pain? Depends. It depends. Sometimes muscle pain can actually be a sign of joint pain that's underneath. And we feel it in our muscles, but it's actually our joints which are hurting or arthritic. And other times it can be pain that's connected actually to a joint that doesn't even feel like it's affected. One thing I often tell my patients is the children's song about the hip bone connected to the knee bone is remarkably accurate for orthopedics. So a lot of patients who have elbow problems are actually complaining of wrist pain, and it's because the wrist is connected to the elbow and the hand is connected to the wrist. That's one of the benefits of seeing someone who specializes in musculoskeletal medicine, which is being able to tease those parts across from each other and then finding a story to put them all back together.
How do we treat this muscle pain? I know that's a loaded question, right?
Well, that's next up for us to try and answer. You know, we use different medications like Cymbalta, nortriptyline, amitriptyline, right? Those I think of as antidepressants or neuropathic pain medications. We usually use them for nerve pain, but we also use them for muscle pain. And the way I see it is, right, if we were normally here at like 0 or 10%, right, just going through life, and now you have disease and issue that raises your pain up to a higher level. When we take things like opioids or Advil or Tylenol, it's going to drop it down and pop back up, just going back and forth. I think of Cymbalta, nortriptyline, amitriptyline as dropping down the pain level to a different level that hopefully can become manageable. And then you use these other medications in addition to physical therapy, in addition to controlling inflammation, in addition to surgeries needed if there's an underlying joint issue to bring that pain down. Is there a simple answer for what works? At least from the kinds of patients I see and treat, there doesn't seem to be. But I think that's, again, the impetus for doing more studies.
Yeah, excellent answer. Dr. Abbey, did you have something you wanted to add?
Oh, that's a good summary.
Okay, great. Thank you. Let's see. Next question is, please discuss why your results did not include breakdown by race, ethnicity, country of origin, or economic status.
Go for it.
And
Yeah.
should I know Dr. Bhai and Dr. Abbey, you didn't have that data. And Emily, do you want to?
Yeah, I can take that. Yeah, I think it's a pretty simple answer. It wasn't an intentional omission or anything like that. This was really intended to be an initial survey just to see pain as a blanket across myositis and what treatments were being used. And we intended this to be a call to action to go deeper. We didn't really know how to parse out past where we went, and we were really hoping that this was going to be an initial statement of myositis has pain, and our patients across the border being neglected, and then we figured that we would, find someone amazing like Dr. Bhai and Dr. Abbey who would help us then go deeper. So it wasn't an intentional omission at all, but we just really wanted to make sure that we could show pain first existed and that people were being harmed by the CDC guidelines being misapplied, and then move forward with it.
Dr. Bhai, you have anything to add to that?
No, you can see from our second, I guess I do have something to add. You can see from our next round of surveys that Dr. Abhiram and I, and then the rest of the MSU crew, we all worked together very closely to have questions that were sensitive, but also encompassing so that we can find disparities or find socioeconomic indicators that certain groups of patients are not being treated the way they should be. And I think this relates to a question here. Someone had asked, or someone put in the chat, how do I maintain privacy when taking these surveys? So these surveys go through the IRB of UT Southwestern, and they're answered in REDCap, where we do not collect any IP addresses. We don't collect any names or email addresses. So there's nothing that I or anybody else can do to connect the data to whoever took the survey. It's completely private and anonymized, and not everybody has access to the rawest of raw data. And that's something that I have with Dr. Bhashyam. But once we distribute it to others to help us analyze and take a look, then it's it's filtered out even more. The data is there, but we just cannot connect it to anybody. So I just want to make that clear, because of course we ask questions that can be a bit probing sometimes, but it's all in the name of helping move the needle forward and has nothing to do with connecting to the person who filled it out.
Yeah, and just to put people's mind at ease, that our original one, it was completely anonymous. We didn't collect email addresses or anything. It was through a Google form, and Google is extremely cautious about privacy when you don't collect email addresses. So it was 100% anonymous as well.
Yes, excellent points to make. Thank you. I have a question here. Why do some people with IBM have pain and others do not? If that's something that you might have a answer for.
I mean, I wish I had an answer.
Right.
I unfortunately, I think it's a similar kind of response that's multifactorial, and some people process pain differently. Some people experience it differently. And some may have had a stronger baseline when they developed IBM versus others who are more sedentary. But I don't have a good answer for that. I don't know if Dr. Bhashyam, if you have anything else.
I don't have a good answer for that, but I think that's a perfect kind of question to follow up based on the results of this study, because that's the whole point of doing studies like this, is to figure out, wow, there's like a difference that's here, but we have no idea why there's a difference between these two groups. And that's exactly the type of research prospective studies are designed to look at and answer. And if you're curious about it, that means that other people are curious about it, and that means that that's something that we should keep going back and looking forward to. So I think that's the perfect type of question to add on to a study like this.
And then bottle the answer.
Right. Lynn, did you want to take some questions from the Q&A?
Okay, let's see. I think that, we have a question up here. Let's see, from Jason, and which I actually can't answer, but it's here anyway. Is there a difference? Are there different opioid guidelines in the U.S. compared to Canada? I cannot answer that. I do not know what the guidelines, if there are guidelines for opioid treatment in Canada. I just know that we have one here, and it has been incidentally updated since 2016 to be more aware of the patient doctor conversation that should be had in managing pain and pain treatment.
So, I can help answer that.
Okay.
There are different guidelines, and they actually vary not just by nation, but by state. And in some cases, they can vary by county. So there are national CDC guidelines, but those are simply a framework in the United States. So every state, for example, Texas is different than the state I practiced in, which is in Massachusetts, which is different than the state I practiced in Washington before that. So every state has its own specific guideline related to prescribing around acute and chronic opioid policies, and the amount and duration at which you can prescribe. And that changes on a national basis too. So Canada is different than the Netherlands, which is actually different than some low and middle income countries. So I've looked at studies comparing United States prescribing to Haiti versus the Netherlands. And it turns out that the protocols are completely different, and there's different levels of state and federal level regulation around them. So the answer is there's a lot of heterogeneity, and it's like that saying about all politics is local. So opioids is something that's actually very driven by local policies and can vary. Even though the CDC says one thing, states can choose to implement it in their own particular way.
Thank you. Let's see.
Manuel, do you have one that stands out for you?
Well, I think there was one that I found interesting because it was about the pathophysiology of pain, of why the air makes neuropathy pain worse. And I think there are some patients who have neuropathy, and I don't know why. So either one of you, Salman, Dr. Abhi, knows what is the role of air and neuropathy. Is there any reason? or not?
And I'll combine this with the question that's a bit later, is neuropathy of the feet related to IBM?
Yeah.
The first, generally, when the nerves get damaged, they are, I call them stupid. They don't know how to come back to where they should be. And when they do come back, they grow in the wrong way and cause pain. And so, Dr. Abhi does nerve transfers, and I've learned a lot from him. And so he talks about how you need to basically get the nerve and give them a path to go back to where it needs to go so it functions properly. But when you talk about pain, it's your sensory nerves, and they're much smaller. And anytime you stimulate them, they get activated in a funny way where now it's causing pain. So if air is blowing on it, you might notice that part of sensation is temperature and feeling temperature. So now they're active, but they're active in a way that causes pain. That's a hand wavy answer. We don't exactly know how and why that happens, but it's also like you may not have neuropathy pain until you lay down in bed at night and the sheet rubs on your feet and that hurts, or you're not distracted during the day or when you lay down, but during the day you don't feel it because you are distracted. So that's another way. And then related to IBM is IBM has mitochondrial pathophysiology. We know that energetics is not functioning properly, and about half of IBM patients have neuropathy. Some of the Charcot-Marie-Tooths, the hereditary neuropathies, are known to be caused by mitochondrial abnormalities as well. So there's this overlap, and that's likely why IBM has some neuropathy as well.
Perfect.
Thank you. We've got some more here. Dr. And I don't know if you saw this, Dr. Bhai. Is it unusual for a person to have pain when your class is being in remission from dermatomyositis? If Cymbalta doesn't work, what other meds could you suggest for pain maintenance and then for pain crisis?
I think it's not unusual to have pain even when you're in remission. The survey seems to suggest that, but it's not a perfect survey, right? I can't fully tell if the data suggests that, but just seeing patients like this, it is common. And I think that's partly due to, may not be active inflammation, but some of the other issues that we talked about that can lead to pain. And if Cymbalta doesn't work, I think it's worth cycling through some of the other medications like the tricyclic antidepressants or some of the other neuropathic agents. There's some medications that we use for fibromyalgia too, like cyclobenzaprine that may help. For the most part, I don't find them to be helpful. And then we have acute pain treatment that Dr. Abhi might have some insights into as well. But that's the strategy, plus physical therapy and improving your physical conditioning.
Dr. Abhi?
I think that's a pretty comprehensive answer, honestly.
We're testing you. Bye.
Can I insert a question that piggybacks on that real quick?
Yeah, sure.
Just because you mentioned the physical conditioning part, I do actually notice that even though I hurt after I exercise, like muscle fatigue hurt, I have less of my chronic pain that night and maybe the next day afterwards. So that kind of dovetails in with what you're talking about. There's something about, and it doesn't last, it's only for that day and that night. If I don't, for instance, I went on a little bit of a walk yesterday at a waterfall with my husband and my daughter, and I was in a lot of exercise pain last night and this morning sore, but my normal convulsive, my back is going to kill me when I'm going to bed pain was not there at all. It was almost non-existent. So that kind of dovetails in with what you're talking about. And that's really interesting. Yeah. I've never noticed that before. You just said that.
Yeah, and you bring up a good point. I think exercise has to be taken in a measured long-term approach. We're so used to with myositis, right? Let's take steroids, knock this inflammation out. We took a pill, things hopefully are getting better. With exercise, it requires, what I tell my patients, is 6 to 12 months of a very slowly progressive program where you won't notice changes in the first few months, and you might even feel worse in the first couple of months. And that's because your exercise tolerance is so low. And so that stresses your muscles, and you'll feel that pain and burn sometimes. But like you're saying, it is different. And over time, hopefully the balance shifts towards that good kind of pain with exercise, and that will improve and get better and better.
Mm-hmm. And so people like me who have that spurt and say, I feel really good today, let's go do something active so I can actually like be a functioning member of my family and then pay for it a couple of days. That kind of goes along with that too. It makes sense then why we pay for a couple of days. But and I have noticed over the last year, because we moved to Minnesota and the weather is more conducive to me being outside, I am getting stronger slowly because I'm doing more of like a walk or a hike or whatever, once a week with my family. But I'm getting to be able to do more and more. But I'm noticing that pain is shifting, even though I'm having the horrible pain most nights. But like my endurance is getting better. So that's really interesting. I had never thought of it that way. So thank you.
Yeah.
Okay, so Dr. Bhai, if you could take a rundown on the Q&As there and do your rapid answer thing that you did at the IGNS conference, like answering 5 questions in 2 seconds. The doctors have to leave at 4:15, so
we've got, sorry, apologies about that. We have a few more patients to see later today, but we do want to get to some of these questions. How would you respond to doctors that diagnose this pain as fibro, not myositis? Is there a correlation between the two? I would say that we don't understand fibro well, and when doctors get confused, they call a lot of things fibro. So I would just be careful about that, but also some of the treatment overlaps. So in my mind, the outcome may not be that different, but it's worth just knowing, is it myositis and is it careful about? So that's just something to keep in mind. We don't want to miss a disease that we should be treating and ignoring for something that is more chronic. There's another question about, is there a contact in Canada? I do not have one. I do not, unfortunately.
Manuel's typing an answer. I'm not sure if he has a contact, but he's typing something back.
It's been my experience that doctors are quick to diagnose depression in a painful autoimmune female more than male, and thereby more willing to quickly apply treatment to pain in men. That is true, and that's because our field has a lot of implicit bias, disparities, and inequities. Dr. Bhashyam just unmuted himself, so I'll let him talk here, but it's a problem in medicine for sure.
I totally agree. There was a similar question about race and looking at race and pain, but I would argue that with garbage in, garbage out. So if you don't do thorough, rigorous analysis of the connection between pain and race and gender or sex, you can start to like mix these words together, even though they're all different terms. And so being scientifically rigorous is really important, because choosing not to study these questions also does a disservice. Like we need to look at them, but we do have to be careful and be conscientious and try to avoid implicit bias when we can. So I think implicit bias is everywhere. It's our job to look out for it and try to combat it. And actually forums like this help us do that, because you get to hear from a lot of people when you're designing the studies. And that's why we did field tests of most of these studies that are coming out.
We just recently published a paper with Dr. Christopher Stein, who led the study with education disparity with dermatomyositis rashes. And it's interesting that nearly 3/4 of the 500 plus images that we looked at from textbooks and online databases were in light-skinned individuals versus dark. And right, I think just what Dr. Bhashyam is saying, if you don't illuminate things like this and interpret it improperly, if you interpret it improperly, you might say, well, it's just more common in lighter skinned individuals and that's it. But that's not true. A similar study came out to show that sexually transmitted infections, the images were disproportionately in dark skinned individuals compared to lighter skinned, right? It just shows you the opposite, where the rest of dermatology has lighter skinned images except for STIs. So I think these studies are necessary to help disentangle some of those implicit bias issues that we have and bring them to light so that we can address them. There's questions on here about how do we get our doctors excited to review this? That's a good question. Free food gets doctors excited. But we'll hopefully present it at conferences and such to help that happen. And, if your doctor doesn't believe you, you can bring out the paper. But, they're busy people too, so I think it's difficult to strike that balance. How is this being socialized to the medical community? So that we're going to talk about it at conferences. Mention controlling inflammation. Other than diet, what do you recommend? Yeah, exercise has an anti-inflammatory effect, plus the medications that you take, I think, are necessary. Diet is good. Eat food that goes bad, eat food that's healthy, and try and keep your weight down, which is difficult when you have steroids on board. And then
I'm just gonna add one point about
yeah, go ahead.
about getting information out into the medical community. One is that I think Dr. Bhai was very thoughtful about what journals to submit to. So submitting to Rheumatology is like a big journal for rheumatologists and people who are focused in this field. So that's number one. Number two is if you think your doctor's not listening to you, just bring them a paper or bring them some piece of scientific literature. It's a lot easier to this is a bias in the medical field, but it's really easy to hear a bunch of case studies. But if you come in with like rigorous data and you come in with a paper, I personally usually will review it and think about it. And it's an opportunity for me to reflect. And oftentimes those are the experiences that doctors then share with their colleagues. So word of mouth is like a very fast way for information to spread throughout the medical community. If you have like Twitters and Instagrams, like it sounds ridiculous that we're saying this, but that's the way of the future. And so patients finding these articles and then posting them on their Instagram feeds or on Twitter or their blogs, that's how the information spreads. And if you think, and doctors are humans too, we all have an Instagram or we have a Twitter or we have a Facebook page. And so we're reading the same stuff. And a lot of times it just pops up. So socializing these concepts to doctors is actually no different than socializing them to any other human. Just keep doing it.
That is true. And the journal did tweet this. And so that's just like you're saying, right? That it's going to spread it. And it's an opportunity for us to all learn, which is fantastic.
100% for this mindfulness question, actually. So mindfulness has been shown to be helpful with neuropathic pain, desensitization type pain. It's been helpful with patients who've had amputations. It's been helpful with patients with major trauma. It's been helpful in almost every setting. It has both effects on psychological abilities to cope. It has abilities to help with pain catastrophizing. It has abilities to help with both anxiety and the real experience of pain. And extending it even further, mindfulness in combination with virtual reality or augmented reality are increasingly shown to be helpful with pain and helping to retrain the mind. And so I 100% think that is a real area for research. It's actually an active area of research for me in orthopedic surgery and pain. And so if folks are interested in that, that is one of the therapeutic type interventions that we were talking about before. So we identify that pain as a problem, maybe mindfulness therapies as opposed to just medication alone is an area to investigate.
And you bring up a good point about studies we're doing, right? I think we need people to participate when they feel comfortable and safe to do so. And so Dr. Bhashyam and I have studies going on, MSU has studies going on, and the goal is not to just publish, right? The goal is to turn something into treatment. And that's what we're after. And it's because of you, right? Because of what you say, because of what you experience, and because of what you're willing to share and bring voice to.
And with that, I would thank the doctors because I don't think I could end with any better comment than that. We do appreciate you being here. We're going to get you back soon. So just figure that into your schedule after Prague.
Yeah. Well, and, that's an opportunity for us to talk about this
and we will, at that point, I think we will have some preliminary results, perhaps from our burden survey. Do you think?
That's the hope. Yep.
Yeah, somewhere in there in a month, we'll have some preliminary results on that. So thank you all for coming and joining us today. I hope you got a lot out of this session and learned a lot from our doctors, and we will see you later on. If you have other questions, we can get those to the doctors, and we will have them back for another session all on pain.